The title of this talk is Blue Light Cystoscopy and where it fits into the non-muscle invasive bladder cancer guidelines. And I'll discuss those specific guideline indications for blue light. But again, I'll talk to you a little bit about how I use it in my practice and why I think it's so important. Trinity and I were talking a little bit before this talk, and both of us really like this tool. I have no financial incentives with blue light. I don't talk for them. I don't get any financial remuneration from them. It just happens to be something that I've used a lot and it's been very useful. So just a little bit of background. So you may know it's an enhanced imaging technique. It uses what's called Cysview. That's the project. HAL is what I'm going to call it because it's really hard to say that word and I always mess it up. You know, interestingly enough, it was first described by Dr. Whitmore back in 1964. So this thought about how we do this has been around for a really long time. And it didn't start getting utilized in clinical practice till about 1994. These are the other names that you may hear it referred to, and I just put those up there so that if you hear somebody saying those things, you know that what they're sort of reviewing. Here's how it works. And so when I explain it to patients, I think it's important to kind of explain. I say, you know, you're going to come to get ready for your TURBT just like you normally would. And they're going to put a catheter in, and that's not all that pleasant. And then they're going to put a dye into your bladder. And that dye is clear, so it doesn't have a color to it. And then they're going to clamp the catheter, and we're going to wait about 45 minutes, and then we'll go back to the operating room. And in simple terms, what I tell them is that this dye is taken up by all cells in the bladder, but bladder cancer cells essentially lack an enzyme to excrete it. So when we take you back to the operating room, we're going to turn on a wavelength of light that happens to be blue that causes cancer cells to fluoresce. And that's sort of a basic way of how it works. And this is what it looks like. And this is actually a patient of mine. This is a picture that I just took not too long ago. And you can see this is almost impossible to see on white light, and this is what it looked like on blue light, and that was CIS. So I think this is, again, a very good example of how you can detect these. Now, I don't use NBI, and I'm not going to talk about NBI a lot, but I know that a lot of people use NBI, and I have no problem with using NBI. It's a lot less expensive. It's oftentimes built into the equipment. It doesn't require a dye. I get all those things. My sort of limited experience is it's not been as good as blue light. And the data on NBI probably doesn't look quite as good at blue light, but just so you know, there have not been any head-to-head trials. So I'm not here to disparage NBI or really talk more about it, but here's an example of what NBI would look like. Well, here's the problem with blue light, I think, and why not as many people have probably utilized it, is you have to have all this equipment. You have to have the special tower, the special box, the special light, the special scope. All of those things are necessary, and so there's a significant startup cost. And when I've talked to other practitioners, they've said, you know, my hospital won't buy this because it's too expensive to get this new equipment. And I certainly understand that. What I would tell you, if you're really interested in that, is say, well, you know what? I could increase referral patterns because people will get sent to me for this technology, and that is certainly what's happened at my own institution, is that people have referred in because they've heard about blue light and we have it, and so they send these patients in. So if you're trying to convince your hospital, that's one way to do it. So here are the FDA indications, and I won't go through these too much in the importance of time, but you know, it's just to point out that this is not a sort of replacement for cystoscopy or biopsy. That's still necessary. It's not like you're just going to use a blue light and say, oh yeah, they had a tumor, and not biopsy that. It's still important to do those things. It really wasn't until about now, I guess 2 years ago, that the FDA allowed us to use it for repeat use. You could only use it once, and then they said you can't use it again. That's now changed, so there was some concern maybe you couldn't give the dye safely more than once, and we've put that to rest, and so you can utilize this multiple times. And also in February 2018, the flexible blue light, so what you would use in the clinic, and I'm going to talk about that in a few slides in a minute, that got approved for use as well. So what are the common indications for blue light? Well, at initial TURBT, if you're suspicious of non-muscle invasive bladder cancer or just bladder cancer, you can utilize it. And some, I think a lot of people, I know Trinity, use it all the time, every single patient. And you know, I don't know that I use it 100% of the time, but I would say I probably use it 80% of the time when I'm taking people back. Following BCG treatment to detect recurrence or progression. So you're really worried, you have that really high-risk patient that you're really concerned about. You see something, you're not really sure if that's something or not. You take them back, you use blue light to help you resect that disease. I will say after BCG, and I'll cover this a minute in a slide, it is a little challenging. Sometimes there's a lot of inflammation in the bladder and it lights up, and it can be a little bit challenging. Some of that is just utilizing a lot. You get this sort of learning curve. You sort of learn what's real and what's not real. So that can be a little bit challenging. In patients with multifocal disease, so people that keep coming back with these recurrent low-grade tumors, that's a great one. I think you're just missing a lot of these tumors, and I'll show you a picture of that in a minute. Patients with high-grade non-muscle invasive bladder cancer that you're really trying to preserve their bladder, I think that's important there. And then probably one of the most important indications that's in both EAU and AUA guidelines is that patients who have a positive cytology, but you cysto them and they're negative, then blue light, I think, can be very, very useful in this instance. And of course, following the rest of the guidelines, which would be to do random biopsies and make sure you're biopsying the prostatic urethra and evaluating the upper tracts. So those are the utilizations of this. Here are some of the contraindications, and again, the main one really is porphyria, which I've never seen a patient with porphyria, but anyway, that would be the main indication, or sensitivity, and I haven't had any bad reactions to HLA. I mentioned this again, so these are the guideline statements. So the AUA basically says, if you have it available, you can use it. And then AAU guidelines also a little bit less definitive would say you could use it if you have it available. And again, if you have a positive cytology, they would recommend that. Here's just the EAU one. If you have it available, they recommend utilizing it. The NCCN similarly says it can be helpful in identifying lesions that are not visible in white light cystoscopy. So here's another example that came from one of my patients. And you could probably see that here, but in clinic that might be a little bit tough, but certainly you can see that very easily in the operating room. So since, what's the data that's out there? So since blue light was introduced in 2004, there have been multiple, and I mean really the literature is replete with studies that have looked at this, and I'm going to go through those, and I'll go through those fairly rapidly because they sort of are repetitive and they also sort of same thing. But basically what they have shown, to date what we have shown is that you can increase detection and you can decrease recurrence. We have not definitively proven that you can reduce progression. And I think that's probably the most important point because really that's what we want to do, right? I mean, particularly low-grade stuff. If you miss one, you have to come back. It's not the end of the world. But we want to change people who are high risk going on to develop muscle-invasive disease or preventing the need for cystectomy. We're close, but we really haven't demonstrated that. But I'll show you those studies here as we go through those. So here again are just numerous studies that demonstrate that you can increase detection rates with this. And again, these are been published in multiple studies. As we go through some of the studies, when you kind of put a summary on that, what you would say is that you can increase your detection rate by using blue light somewhere about 15 to 40% improvement in detection. Now, 15 to 40%, what does that really mean? Well, I mean, obviously that depends on who's doing it, right? If you have a lot of experience in bladder cancer, it's probably, not on that 40%. If you don't have a lot of experience, then it's probably a little bit higher on that 40% increasing your detection rate. But if you kind of look, it just sort of depends on the study where you're sort of seeing that come through. Probably one of the most important points, and I'll show you on this slide and on the next, is detecting CIS. Those are the ones I think can be challenging in the clinic, right? Or in the operating room. You get in there, you see a patch of red, you're not really sure what that is. I think blue light in that instance can be very, very helpful to help me detect CIS, and I'll talk about why I think that's important in a minute. This was a really nice study that was a multi-center German study, a large number of patients that basically, again, just demonstrates that it increases detection. This was a study that was recently published out of Hopkins, and what it basically did was look specifically at carcinoma in situ. And what it showed was that using blue light, they had a 93% sensitivity in detection and a 94% negative predictive value. So that means that they didn't miss these lesions. 46% specificity, that's the challenge. So my bias, and again, as I sort of said at the beginning, I'm going to give you sort of my biases and opinions, is that you're going to end up resecting lesions that don't end up being CIS. They're positive on blue light, but they don't end up being any kind of cancer. My sort of feeling is, so what? If I can do it safely, and I can most of the time, then I think it's worthwhile resecting all these lesions. I get a lot of patients sent to me with this, non-muscle invasive bladder cancer that's BCG refractory. And, they're either not very good candidates for cystectomy or they're highly motivated to keep their bladder. And what I say is, let's take you back, let's use blue light, let's resect all of the lesions. I may resect stuff that's not positive, but if I want to give that patient the best chance of responding to BCG or not having recurrence and keeping their bladder, I think I'm going to be aggressive with my resections. So the flexible data. So this was a study that was published supporting use of blue light in the clinic. And there are other studies out there as well, and there's one that'll be coming out probably before too long. This was a study that looked at 304 patients. And again, what they demonstrated was that they could identify more lesions in the clinic. And Trinity and I were talking a little bit about this, and the challenge, I think, around flexible cystoscopy in the clinic is a couple of things. Cost effectiveness, so obviously expensive equipment, and we really haven't demonstrated that picking up these more of these lesions in clinic is useful. Number two, I don't really know, and I think it's a very small number, of patients who you miss if you are using white light cystoscopy and cytology in FISH and you miss a high-grade lesion. I think that happens very, very rarely. And that really hasn't been ferreted out very well in the flexible blue light data. So, if you miss a low-grade lesion in the clinic, not the end of the world. You'll probably catch it on the next one. But a high-grade lesion, those are the ones we really want to detect. I don't think we really miss that many if you're utilizing all those things. The other thing that I think is probably the biggest factor, again, Trinity and I were talking about this, is that the flow in clinic. They have to come in, they have to get the catheter, they have to get it instilled in their bladder, they have to wait an hour. How you manage that in your clinic practice when you're doing 8 or 9 cystos in a half day is really challenging, and I haven't figured that out. So I think those are some of the challenges, but the data do support its use if you're trying to increase detection in that instance. And again, so just sort of in summary that, we can detect more tumors and we can decrease recurrences because we can identify more of these lesions. And again, here are just a number of studies that show that we can increase detection, decrease recurrences. These are some of the prospective studies. And again, the odds ratio is about 0.84, so about a 20% reduction in recurrences. And again, I think it depends on the study which you read. And it depends a little bit on the population in which you're testing it. But I think this is really, really important, is that we can detect lesions, we can decrease recurrences. And what we can also do is decrease that time to a recurrence. So again, we're doing a better job resecting. They have longer disease-free intervals, and that's really important. I do want to point out this one point here from Bart Grossman's study. And again, I think this is a fascinating thing. In his study, they were able to demonstrate that they could decrease the number of patients that required cystectomy. Now, again, this is not really powered to show a significant difference here, but again, that's our main goal. Can I save someone's bladder? Can I decrease the need for cystectomy? And this study would suggest that you can. So, as I mentioned, I think that blue light can be particularly useful at detecting carcinoma in situ. And why is that important? Okay, here's where I'm going to put a target on my back. I do not believe that you can leave CIS and treat it with BCG and it works. I don't believe that. I think you need to take it out or you need to get rid of it. Now that is, Trinity's smiling. That is not what EAU guidelines suggest. The people think that that's not true. But I think if you want to have a good chance of getting rid of CIS and keeping it away, you should resect it. Then give them BCG. Well, what data is out there to suggest it? I've already shown this slide. This slide does include patients with CIS, and it shows that if you resect and you can get rid of the disease, the chance that that disease stays away is better. And again, I think this is where blue light can be really, really helpful. Again, just showing if you find no residual disease, they have much better outcomes. I mentioned this, and I just want to go through this slide real quickly. Ashish Kamat looked at the data on progression, and there was a trend towards increased time or decreased rates of progression, and it was important that they specifically defined how progression was. So change in T stage, change to T2 grade, or change from low to high grade. And again, the trend was an improvement progression, but they were not able to demonstrate significant improvement in progression. There are studies that suggest it is cost effective, because that's one of the things out there, is it cost effective? And certainly in the OR, decreasing recurrences, time having to go back to the OR, it does, through multiple studies, appear that that is effective. Again, there's no direct head comparisons of NBI versus blue light, but there was a recent meta-analysis that demonstrated increased rate of detection with NBI, but no reduced recurrences, and that's been shown maybe in a couple of studies. So again, I'm not here to bash NBI. I think it's fine, but it's probably not as effective as blue light. There is an additional CPT code for blue light that you can put in. Here are some of the future directions, which is the oral administration. That would be sort of one of the holy, I wouldn't say that's the holy grail, but that would certainly help us with this. The challenge has been photosensitivity. The holy grail would be putting this into the bladder and then just being able to shine a wavelength of light that would destroy the bladder cancer cells. And some people have been working on that, but again, we're not there. But I think that's sort of the holy grail on that. So again, finally, where do I use it? I use it in patients that are referred for recurrent bladder tumors or BCG, quote, refractory disease. I think that many times that's just unresected disease, and if I resect the disease, they have a much better chance of responding to additional treatments. Positive cytology, but negative cystoscopy, it's great for that. Re-resection of high-grade T1, again, if that patient's motivated to preserve their bladder, then I'll go back and do the re-resection with T1 and multiple recurrent low-grade tumors. So I think it's particularly important for detection of CIS. It does appear to be cost-effective, and it is supported by the use of guidelines. Thank you very much.